Good morning, good afternoon, and good evening to all of you who are joining us across the globe. My name is Gráinne Maloney, and I'm a Senior Nutrition Advisor with UNICEF in New York, and I am passionate about breastfeeding as the ultimate intervention to protect all children across the globe from all forms of malnutrition. I'm delighted to welcome you all to our annual World Breastfeeding Week webinar, which is hosted by the Global Breastfeeding Collective. And our focus for today will be on taking 10 steps up for breastfeeding. I see many of you are joining online, so perhaps I'll just wait another 30 seconds and then we'll get right in there. Before we get started, I would like to draw your attention to the interpretation options for this event. This event is being interpreted in English, Spanish, and Portuguese. Please choose your preferred language by clicking on the interpretation button. You'll see that at the bottom of your screen as illustrated here on this slide. Please also note that part of this presentation will be in Spanish. It's the later session on the panel. And those of you who would like an English interpretation for that session should choose the English channel now. However, there is a risk there might be some interference on that line. So if there is, you can come back to the main channel. So thank you for celebrating World Breastfeeding Week with the Global Breastfeeding Collective. The Global Breastfeeding Collective is a partnership of prominent international agencies calling on donors, policymakers, philanthropists, and civil society to increase investment in breastfeeding worldwide. The collective's vision is of a world where all mothers have the financial, emotional, technical, and public support they need to start breastfeeding within an hour of a child's birth, breastfeed exclusively for 6 months, and continue breastfeeding for 2 years or beyond. And we are here today because the 10 steps to successful breastfeeding are evidence-based practices that improved breastfeeding rates by establishing benchmarks for quality care for new mothers and infants in maternity services. We are very pleased to be here with you today to explore the 10 steps, learn about resources to advocate for and implement these baby-friendly practices, and get inspired by local experts. So let's get today's agenda started. We have a fantastic agenda for you all. As mentioned, we will get an overview about why the 10 steps are so important and learn from an expert panel. And you'll have an opportunity to pose questions and learn more about what they are doing. Can we move? Yeah, move the slide. Thank you. Immediately following this session, so you'll see here we have the welcome and opening remarks, and then we'll invest in the 10 steps. We'll have our panel, and then immediately following this session, we will be handing over the mic to the Mammy Global Network and the Infant Feeding in Emergencies Core Group to learn 2 more ways that you can step up to save lives. So please do stay on for the full 2 hours because it's going to be a fantastic session with lots of fantastic information to be shared for all of you. If you would like to, a bit of housekeeping now, if you would like to enable captions during today's webinar, you may do so by clicking the 3 dots and then selecting Turn on Live Captions as is illustrated here on the slide. However, please note that this feature is only available on the computer version of Zoom. Importantly, if you have any questions today, especially after our panel, please make sure you use the Q&A function. You'll see that on the bottom of your screen. Please do not place them in the chat because it gets difficult for us to manage. However, if you are having any technical issues, you're welcome to add those messages in the chat. I see many of you are introducing yourself, which is fantastic. We're very excited to know who is joining us and from where, and we are keen to get to know as many of you as possible. So please keep posting your name, where you're from, and what you do in the countries that you are joining from. So let's get started. And I'm delighted to introduce our first speaker, Dr. Victor Aguayo, my boss, who is the Director of Nutrition and Child Development at UNICEF in our headquarters. Dr. Aguayo brings 30 years of policy, program management, and humanitarian experience in maternal and child nutrition in Africa, Asia, Latin America, and globally. His work is guided by the belief that hunger and malnutrition are a violation of children's rights. So handing over to Victor.
Colleagues, it is a great pleasure to welcome all of you to the 2022 World Breastfeeding Week webinars of the Global Breastfeeding Collective on behalf of WHO and UNICEF. First, let me thank all of you, each one of you, for your work to protect, to promote, and to support breastfeeding for mothers and for children everywhere. As we all know, breastfeeding is one of the most effective nutrition interventions and the best start in life. Breastfeeding is also a great social equalizer and the right for children and mothers. Now, with multiple crises across the globe, breastfeeding is more important than ever, not only for the survival, growth, and development benefits for millions of infants, but also for a sustainable planet. For this year's World Breastfeeding Week, we are focusing on the 10 steps to successful breastfeeding, also known as the Baby-Friendly Hospital Initiative. We want to accelerate progress towards our global breastfeeding targets. As many of you know, over the last 4 decades, an estimated 900 million infants globally have enjoyed the survival, growth, and development benefits of exclusive breastfeeding in infancy. The implementation of the 10 steps has made a significant contribution to this achievement, demonstrating that positive change for breastfeeding not only is possible, but is happening at scale across countries and regions. And while there has been huge progress over the last 4 decades, much remains to be done. Currently, only about 44% of infants are exclusively breastfed in the first 6 months of life. And new forces threaten progress. Forces such as increasing inequities, conflict, climate change, the COVID-19 pandemic, and of course, unethical marketing practices. Therefore, your work is essential to ensure that we continue to make progress towards our collective breastfeeding targets for 2025 and 2030. We at UNICEF and WHO are committed to sustain our support to the Baby-Friendly Hospital Initiative and its programs across the globe. We want to update guidance, we want to update tools, and we want to help governments ensure that all women and children benefit from quality breastfeeding policies and programs. With our support in UNICEF, the number of countries implementing the initiative and the 10 steps to successful breastfeeding in maternity facilities has continued to increase. Today, more than 100 countries across the globe are supporting and strengthening the BFHI in their healthcare systems. So today, I encourage all of you, all of us, to strengthen our collective resolve to do 3 things. The first one, to scale up BFHI to universal coverage and to make sure that we reach those children and women most at risk everywhere. The second one, that we ensure the sustainability of the BFHI by fully integrating the 10 steps into all elements of the healthcare system. And third, that we strengthen the existing standards of care based on the updated guidance. Thank you again for all the work you do in making sure that every child's right to nutritious food, to affordable food, to adequate nutrition is realized from the beginning of life, starting with breastfeeding. Thank you very much.
Thank you, Victor, for those inspiring words, and fantastic to hear of the commitment of UNICEF at the start of this important webinar. And it's also fantastic to see so many friends and colleagues from around the world posting their names in the chat box. So please keep doing that so we see who's online. Now, next we're going to listen to a video from Alison Tomilovic, who is a Senior Program Officer on the Maternal, Newborn and Child Health team at the Bill and Melinda Gates Foundation, which she joined in 2019. Within this team, she focuses on maternal, infant and young child nutrition investments, aimed at answering questions of how implementation can be improved so that interventions can have greater impact at scale. So over to you, Alison.
Thank you so much for the invitation to join you today. It's a pleasure to speak with you about the importance of investing in breastfeeding promotion, protection, and support. This year, World Breastfeeding Week is happening during an extraordinary time. The compounding impacts of the COVID-19 pandemic, conflict, and climate change have triggered a global food and nutrition security crisis with devastating consequences. In this global climate, investing in breastfeeding is more important than ever. We all know what's at stake, and we know the numbers. Scaling up optimal breastfeeding practices could save the lives of 800,000 children under the age of 5 and prevent nearly 100,000 deaths among women from diabetes, breast and ovarian cancer each year. And the economic benefits are just as extraordinary. Researchers estimate that suboptimal breastfeeding costs $340 billion each year in avoidable healthcare costs and lost earnings. And yet, there's been little increase in donor funding to support breastfeeding. In fact, recent analysis shows funding has actually plateaued. This is no time for donors to delay. This is the time to step up and commit to funding cost-effective, proven interventions like breastfeeding that will dramatically improve health outcomes for women and babies. Despite stagnant donor resources, many national governments have recognized the positive impact that increased breastfeeding can have in their countries. They are stepping up and leading, with real change happening at country level. We see governments promoting breastfeeding through regulations and changes to health systems, such as implementing the Baby-Friendly Hospital Initiative. We know that the BFHI has the potential to significantly increase success with breastfeeding. For example, one study found that adherence to 6 of the maternity care practices could reduce the odds of early termination of breastfeeding by 13 times. In Malawi, we've seen revitalization and scale-up of the BFHI in health facilities across the country, providing counseling on exclusive breastfeeding to more than 80,000 mothers prior to discharge. We've also seen increased attention to the International Code of Marketing of Breast Milk Substitutes. Between 2018 and 2020, 44 countries around the world strengthened their protections against inappropriate marketing of breast milk substitutes. This is a step in the right direction, though we need to continue to strengthen and enforce these policies to curb aggressive and misleading infant formula marketing. Country-level political leadership is now paying dividends, with an almost 7% increase in exclusive breastfeeding rates for children under 6 months of age over the last 8 years. But this is far below where we need to be in order to meet the 2030 global target, and it's going to take a lot more than political will to get us there. This community has long recognized that we all have a role to play in enabling optimal breastfeeding practices. It is not solely the responsibility of mothers. It takes many individuals at different levels throughout the health system, the community, the workplace, at home, to collectively create an environment that educates, encourages, and supports mothers. We need donors to do their part, to make investments in proven and context-specific interventions to help countries further scale up breastfeeding. At the Bill and Melinda Gates Foundation, breastfeeding has been a core component of our maternal, newborn, and child health and nutrition strategy from the beginning. And in partnership with many of you, we continue to support breastfeeding in several key ways. We're investing in infant kangaroo mother care, which involves skin-to-skin contact together with exclusive breastfeeding. A recent landmark study showed that immediately initiating KMC, rather than waiting until the baby is stabilized, increases the chance of survival by 25%. This simple shift could save 150,000 newborn lives each year. And for mothers of the most vulnerable newborns, we are investing in developing tailored breastfeeding support. We are supporting research in Bangladesh, Ethiopia, India, Malawi, Nigeria, Pakistan, Tanzania, and Uganda, exploring how to best deliver this kind of specialized lactation support. And we're continuing to expand and update the evidence base for breastfeeding. The forthcoming Lancet series on breastfeeding will cover the latest epidemiology and statistics and take a deeper look at the impact of breast milk substitute marketing on breastfeeding. The bottom line is we can and we must do more to meet this moment and to support mothers, starting in antenatal care and continuing throughout their breastfeeding journeys. We know progress is possible. And if we do our part, donors, policymakers, and civil society, to invest in breastfeeding to meet this moment, the impact could be transformational. Thank you again to the Global Breastfeeding Collective for your critical work, and I look forward to the rest of today's session.
Thank you so much to Alison, and indeed the Gates Foundation, who have been one of the major supporters of investing in breastfeeding programs across the globe. And in fact, as Alison said, Funding levels are insufficient for scaling up breastfeeding programs across the world, despite the extraordinary evidence base where she gave us some of the gems of the benefits of breastfeeding. So if there's any donors online, now is the time to scale up efforts, now more than ever. We are facing a global nutrition crisis like no others, and we need to do more to scale up efforts. Now we have a really special video we'd like to share with you, which is the voice of mothers. And I'm going to hand over to Nina to play the video and really sit back and enjoy. The video is coming.
Apologies, we're just getting there.
Please keep posting your names and have a look and see what friends you're connecting with online.
Night feeds are the hardest.
You're worrying about is my baby getting fed enough?
When they give birth, they had
the first few days after birth, the baby was always hungry, crying.
It hurted so badly.
I was not very sure of the correct technique to breastfeed my child.
I come from a breastfeeding household.
I was determined to breastfeed.
Breastfeeding has allowed me to establish a connection with my son and get to know him better. We've created this beautiful bond together.
It's the best nutrition your child can get.
I received skin to skin as soon as my daughter was born, and support from the nurses and the lactation consultant.
She was on my chest for probably about 2 hours before the midwife actually then did all of her weighs and checks and things like that.
The head nurse helped me solve an issue where baby did not want to breastfeed on one side. Changing to a different position for feeding on that side solved the issue.
I was not very sure of the correct technique to breastfeed my child, so I struggled till the time the nurse came to my rescue. As the days went by, I became a pro.
Since my baby was a prematch, I had to do like a kangaroo, so it was always kept on my chest as I was feeding him in between the kangaroo.
She also gave me supplies needed to clean my pump parts and syringes to help feed baby my pumped milk. I pumped to help the side the baby was not nursing from until we found a solution with a different position.
They supported and helped me with positions and how to recognize hungry signals.
My baby was with me the entire time I was in the hospital.
And then when we were home a couple hours later, I called the breastfeeding counsellor and she came over just to make sure everything was going well in terms of breastfeeding, and she was latching properly, which was really great.
And I'm really glad that I stuck with it and got the support and help that I needed.
I gave my baby exclusive breastfeed for 6 months, and I continued breastfeed up to 2 years. And I am very happy to say that my baby is very healthy.
I fed him for 2 years, so thanks for everyone who helped and supported me with my breastfeeding journey.
Los invito a practicar la lactancia y sobre todo a los empleadores privados y gubernamentales establecer políticas que ayuden a las mujeres.
Help to continue this practice to better health for themselves and for their children.
Well, what a wonderful video. And this is really what it's all about. It's supporting these mothers with the counseling, the guidance, everything that they need to achieve their goal and their desire of breastfeeding their baby. And it was a nice illustration of how each of the different 10 steps have a role to play in a successful outcome for those mums and babies. So we will make sure, obviously, I think a lot of you love that video. We'll make sure it's available and circulated with a recording of this webinar. But now I'd like to move on and introduce somebody who most of you will know, if not all, Dr. Lawrence Grumberstrom, who is the unit head of the Food and Nutrition Actions and Health Systems unit at the World Health Organization in Geneva. He coordinates WHO's work on infant and young child nutrition, treatment of acute malnutrition, and prevention of micronutrient deficiencies. So over to you, Larry.
Thank you, Rania, and good morning, good afternoon, good evening to everyone. That video that we just heard was a wonderful introduction to this issue of really supporting women with breastfeeding. Each of those mothers showed how they had difficulties, but it was through the application of the 10 steps that they were able to really come to the support that they needed. What we're really talking about here is how do we make these 10 steps to successful breastfeeding a reality, not just for selected mothers, but for all mothers. How do we get every newborn to get the kind of care that she needs? So let's start off with being very clear. We know that these 10 steps work. Implementation is absolutely critical for breastfeeding to succeed. In 2017, WHO published a series of systematic reviews looking step by step within the 10 steps and sometimes even sub-steps within them to really make sure that we were talking about evidence-based practices. And it was clear these are evidence-based practices on how do we support breastfeeding. I just show one study that was identified here that really showed the importance of the package of the 10 steps. Mothers who did not experience a care in the first 24 hours that was conducive to the 10 steps, were 30% of them had stopped breastfeeding by 6 weeks of age, of their baby's age. Whereas if they did get the care, only 3% of them stopped. It's a significant difference of what kind of support this first 24 hours can in supporting the continuation of breastfeeding. Next slide, please. So we want everyone to experience this. But the challenge that we have is that throughout the history of the 25 years at the time that this study was done in 2017, we were only able to achieve 10% of births occurring in baby-friendly facilities. And we thought we really need to be doing better. When we looked at the map around the globe, only a handful of countries were actually able to reach a majority of infants. And so many children around the world were being left out. So we looked to see what can we do better about the implementation to make sure that these 10 steps really do become the standard of care. Next slide, please. So we started a process to bring together experts around the world who really understood the implementation of the baby-friendly. They looked at case studies, they looked at key informant interviews around the globe. They looked at a survey that WHO had administered to all countries about their implementation and the challenges that they had faced with implementation of the 10 steps. We brought the world together in a Congress in 2016, 130 countries represented there to discuss how could they implement the Baby-Friendly Hospital Initiative in a more sustainable way, in a way that would reach more infants. But once the document was written up, it was sent out for public comment. We had lots of dialogue with various civil society organizations about how do we actually make sure we're capturing all of the needs for this program, and finally published this in 2018 in an implementation guidance that I want to talk more about today. Next slide, please. So there were two major objectives that the new guidance for baby-friendly is trying to focus on. One is we have to reach all babies. It's not good enough that after 25 years, we've only reached 10% of babies around the globe. We have to make sure that the 10 steps are the standard of care. They are the appropriate way of providing care for all newborns in every facility around the world, not just facilities that want to get extra credit in some way or show off that they're doing something better for babies. And the second objective was to really emphasize that we have to do this in a sustainable way. The evidence around the baby-friendly implementation had been that hospitals struggled with maintaining the 10 steps over time. They would prove that they could do it when they were going to be designated, when they were going to go through their assessment visit. But when we went back to visit them several years later, they had oftentimes fallen away from many of the practices. And national programs themselves were hard to sustain over time, very much reliant on external donors to come in and put an emphasis on vertical programs to designate hospitals. And it worked great when they were doing that, but it was very hard to sustain over time. Next slide, please. So what we ended up developing was a way of looking at national programs for how do we actually systematize and integrate a national baby-friendly program to make it sustainable and really reach all hospitals. It needed to have national leadership and coordination. It needed to establish policies, professional standards of care for pediatrics, neonatology, nursing, midwifery, all of them recognizing that 10 steps are the way to provide care for all babies. We need to have better health professional competency building. We need to have an external assessment process, incentives and sanctions, so that we can actually encourage hospitals to make the changes. And if they're not making these changes, we actually hold them accountable for what they're not doing right. Building systems for technical assistance to facilities so that they can work out how do they actually make the changes that are necessary. We'll come back to an external assessment and talk about it a little bit more in depth. So next slide, please. So on external assessment, it was really important for us to recognize that we need to do this in an integrated and streamlined way. It's not necessarily for the purposes of just getting a designation that you want to check a box or you want to get a plaque on the wall, but we actually have to do this assessment in a way that is integrated with other systems that can be sustainable over time, but hold facilities accountable for actually applying the 10 steps. So why did we kind of say we want to de-emphasize the importance of designation? One of those was that we recognized that designation really has been an expensive proposition for both hospitals and for countries. It was difficult for the hospitals to actually go through the process of all of the quality improvement that they needed and to then demonstrate step by step all the things that they were doing. And it was expensive for countries to actually run a program that went hospital by hospital, checking that they were doing everything right. And therefore, it was difficult to sustain. We also found that for many facilities, the promise of becoming designated really wasn't a strong incentive for them to do quality improvement. It was exciting for the time that they were working on it, when they got their plaque or they got an article in the newspaper about the great work that they were doing. That was exciting. But after time, this kind of fell away and it was no longer the focus of attention. It was very dependent on the publicity, advocacy efforts to draw people's attention to it. And oftentimes it depended that there was some competition for facilities that it was the only place to go to for having your baby. They didn't really care too much about getting that designation. It was only when they were kind of competing for attention in the market to get more babies born in their facilities. And finally, from the quality improvement literature, we learned that actually internal monitoring on an ongoing basis that really focuses on continuous quality improvement is much more effective at sustaining quality practices. Next slide, please. Just to round out the last of the 9 responsibilities, back up one, we also talked about the importance of national monitoring. We need to actually hold facilities accountable, but we also need to hold countries accountable for, are they really focusing the attention where it needs to be? How are they doing with the implementation over time? We need better advocacy efforts, and we need to ensure that there's financing for this from national sources so that it can indeed be sustainable and not dependent on donors. Next slide, please. Some of the additional key points were that we needed to make sure that national standards of care for all of the professions are based on the 10 steps. We need to make sure that the adoption is related to a continuous quality improvement approach and therefore is reliant on internal monitoring on an ongoing basis. We need to shift from project implementation to a systems approach for quality assurance. And we need to shift the focus from healthcare providers, rather than just having training per se, getting them to really focus on having the competencies and skills that they need. And finally, it really emphasized that preterm and low birth weight newborns are definitely part of the 10 steps and cannot be left out. Next slide, please. We won't have time today to go through each of the 10 steps in detail, just to list that we are still dealing with the same topics that we always have dealt with since 1989 when these came out. So we're still talking about the same topics, but there have been some changes to the wording of the steps to emphasize certain aspects that were most critical and were the most related to the evidence that they come from. Next slide, please. So I'll just highlight a few of them. In step 1, we added that the compliance with the Code of Marketing of Breast Milk Substitutes is a critical part of these policies. Previously, it wasn't mentioned in the steps. It was only there for designation purposes, but wasn't considered part of the 10 steps. So that was an important change. And we needed to add internal monitoring for this continuous quality improvement. Step 2 shifted its focus to really focus on the assessment of competencies of staff, not necessarily providing them a course. Maybe that course they'd had before they came to the facility. Maybe they didn't actually need additional training, but we needed to make sure that they actually had the skills necessary for providing optimal care. Step 4 started out talking about initiation of breastfeeding in the first hour early on back in 1989, and then it kind of shifted focus to skin care. And finally, in 2018, we really emphasized that both of those are absolutely critical, and we need to be accountable for both of them. Next slide, please. Then we look at step 5. In step 5, we really focused much more on practical support. The original 10 steps were really focused on kind of key messages to give mothers, but we really wanted to make sure that this was practical support mothers are getting, and that the staff are ready to deal with any difficulties that mothers might have, that they're able to really work in a counseling mode to understand the issues that a mother is facing, and the questions that she has, so that she's really getting her skills built in order to sustain breastfeeding over time. Step 9 changed a little bit to focus more on the counseling around the use of pacifiers rather than an outright ban of them, because it was recognized many mothers are going to use pacifiers, and we need to make sure that they are clean, hygienic. And the evidence really didn't support an absolute ban on pacifiers for the care, particularly of small and sick newborns. In step 10, we focused more attention on the responsibilities of the facility itself, the birthing facility, whereas step 10 had been talking about what needed to happen in the community. We've really shifted the focus to really talk about what the responsibility of the facility is and allow multiple options for follow-up care. Mother-to-mother support is a critical step, but it's not the only way that mothers can get the follow-up care that they need for continued support for breastfeeding after she leaves the facility. Next slide, please. So I just want to end today with just pointing out that there are a number of resources that are available on the WHO and UNICEF websites for how you can implement the 10 steps with these new tools. We have a competency verification toolkit so that you can check the skills and competencies of staff, training courses for the BFHI specifically, as well as for IYCF in the community and prenatal counseling. We have a manual on applying the BFHI for small, sick, and preterm newborns. We have resources about the code of marketing specifically for the responsibilities of health workers. We have a model chapter for pre-service training so that people are getting their training before they get to the facility, not relying on each facility one by one to give them that kind of training. And we're updating that chapter right now. Next slide. I just want to thank you very much for your attention today. I hope that this is helpful to orient you to some of the key directions that we're trying to move with taking the 10 steps to a new scale. It is truly time for all of us to take 10 steps up so that we can support all babies around the world in every facility. Thank you.
Thank you so much, Larry. I think that was a fantastic presentation. Providing us an overview of where we are right now in the guidance, but also a refresher. I'm sure many of us online really benefited from learning about the changes in 2018 and then some of the forward-looking plans on updating these guidance as we move forward. I think the two objectives we need to remind ourselves again are why these were updated. One is the universality. All babies everywhere across the globe have a right to these standards of care and these 10 steps, and that is so important in the work that we do. For an equity focus. And then secondly, the sustainability option. We really need to make sure, not option, but sustainability objective. We really need to make sure that these 10 steps are fully integrated across health systems and resourced and monitored and have that quality element to it. So these are really important in our work as we go forward so that we can increase the reach well beyond where we have been in recent years. Now we're going to hear a bit more about real-life examples, and I'm delighted to introduce our panel. So many of you maybe perhaps have been on the first webinar that we held this morning, which was more focused on the European, Africa, Asian regions, and where we had experiences from those regions. And for this webinar, we're looking more at the Americas for some examples of some best practice. We're going to start with Bolivia, with Dr. Carmen Lucas, and Dr. Lucas has more than 30 years of experience providing technical assistance in the definition and implementation of health, nutrition, and HIV/AIDS policies and strategies to the Ministry of Health. She promotes health and nutrition initiatives, including the 10 steps, and works in health education, protection, water, and sanitation in Guarani and the Amazonian areas of Bolivia, with a focus particularly on strengthening the indigenous people, especially women. Dr. Lucas will be followed by Lieutenant Colonel Janet Anderson from the US. Jeanette is a perinatal clinical nurse specialist serving in the United States Air Force. Currently, she is the Director of Clinical Investigations at the 88th Medical Group Wright-Patterson Air Force Base, Ohio, where she oversees clinical research and evidence-based practice implementation. She has served as the Air Force Surgeon General's perinatal nursing consultant and is now serving as the evidence-based practice consultant. And then finally, we move to Mexico. And Dr. Mariana Colmenares is a doctor with a specialization in pediatrics and breastfeeding medicine. She has more than 14 years of experience in community child health with high standards in professional and humanistic attention. She's experienced in counseling, education, and training healthcare professionals, and she has expertise in clinical investigation, collaborating locally with the National Public Health Institute and UNICEF in Mexico. So we'll hear from each of our speakers for about 5 minutes, and we will start with Dr. Lucas. Dr. Lucas, over to you.
Muchas gracias.
Thank you very much. The initiative of friendly hospitals in Bolivia had two instances. One that we may consider before the law to foster breastfeeding, and the other one after the law, before the breastfeeding law. In Bolivia, the initiative of baby-friendly hospital was driven by UNICEF, WHO. We had a technical committee for the breastfeeding, but also the nutritional program from the ministry. And based on resolution, we work on this initiative that through its implementation had advancements, but also many limitations. And among those, everything that imply the marketing of substitutes and all of that. In this first stage, from 2006, few hospitals were credited as baby-friendly hospital, mainly in 3 regions. But after the law came out to foster breastfeeding, the scenario completely changes because the law and its regulation promotes the implementation of the 10 steps of the baby-friendly hospital initiative, and Bolivia adds an extra step. So this law establishes everything that we should do to foster breastfeeding, and sanctions as well, and not only in the health sector, but in every part, in every instance, mainly the marketing, because it was a problem to enhance the initiative. From the law, our regulations we established, thank you for, oh, that slide is good, thank you. We established now a regulation on the baby-friendly hospital initiative, and based on this regulation, we start working from the Ministry of Health, but after that, with the 9 regions of the country. We train facilitators of this initiative, and we start working not only in 3rd-level hospital or maternity wards, but 2nd-level hospital and primary care hospitals where they see after deliveries, because we can follow the 11 steps even on these installations. As been said before, it has been so important for Bolivia. In the law, it's established that there should be a committee per hospital. And of course, the compliance of the 10 steps, and we have added the 11th step. And it's linked to eradicating any type of promotion, marketing, on all kind of pacifiers and bottles at the hospital. So now we have the regulation, the training of the staff, and now if you can move to the next one, please. Then here are the other steps, 5, 6, 7, and the 10th I mentioned. The 11th, eradicate the free distribution of the substitutes of breast milk. but also to tell you that in the Bolivian experience, how important this law has been to create the committee of breastfeeding, of course, to comply with the 11 steps, but also to motivate the staff. Every member should follow the law and they must be trained as part of the law, that training. So we must motivate them to get trained. Next, please. The 11 established steps in the baby-friendly hospital initiative are fundamental and important. In the Bolivian experience and with the work done, we see three fundamental steps. First, to inform through the prenatal care about the importance of breastfeeding, but only to pregnant women, but the environment, because some mothers stop breastfeeding because of their environment. So that's why it's so important. Also to show the mothers, mainly the first mothers and adolescent mothers in Bolivia, we have many of them, in a practical way, how to breastfeed. And everything is vital, the position and everything. It's a practical teaching that we give in the first 24 hours of birth. The other one has been the creation of the support groups at the hospitals, which is where mothers connect with, where they can actually clarify concerns and ask questions. And throughout this, also in a hospital, is important the director commitment and the managerial commitment. If we have support from them, the initiative is implemented. Next, please. And then Bolivia, with this law and its regulation, along with the commitment of the Ministry of Health, UNICEF, PAHO, COTALMA, everybody involved in the fostering of breastfeeding has been moving forward, but there are challenges, of course. And our breastfeeding prevalence is 58.3. We hope to increase this. We're going to have a census soon. We've been working a lot of that. And right now, 277 hospitals and health centers have been credited as baby-friendly hospitals. And these are hospitals that look after delivery of child and all the way to primary care. It's a total of about 1,300 hospitals. We still have an important challenge. What Lawrence mentioned is fundamental as well. This baby-friendly hospital initiative is tied to quality. It's part of the quality of the healthcare system. And now people, the user, want to go more and go more because this is a strategy. This is an initiative that improves the quality of care, and we must focus on this. In Bolivia, the accreditation is something very important because when the hospital is created, the staff feels committed. If you can show the next slide, please. See, I want to show you, it's like a party whenever a hospital is credited. The authorities of, from the Ministry of Health and UNICEF are there. This is an important event is planned. And at the end of the year, we do the crediting. Thank you very much.
Thank you so much, Dr. Carmen Lucas. I think that was a fantastic example and some very practical summaries of what really worked, the increased focus on quality counselling, skilled counselling, the creation of the mother support groups at the hospital, and then with the technical assistance, and then of course acknowledging the success and a very impressive 58% goal reach. So we're looking forward to seeing the latest excessive breastfeeding rates in Bolivia when it comes to your next survey. I'm sure it will translate into improved outcomes for children. I'd like to remind all of you online to please post your questions if you have any for the Bolivia team in the Q&A box. Much is popping up on the chat, but we actually need to make sure it's captured in the Q&A box. And we have a group of experts online who will answer your questions, as well as the team from Bolivia. So please direct your questions into the Q&A box. Now we're going to move a bit north. We're going to come to the USA, and Lieutenant Colonel Jeanette Anderson is going to take us through her experiences. Jeanette, over to you.
Hello, I'm excited to share a little bit about the journey that the Air Force took as we implemented the 10 steps across our different hospitals. On the next slide is just the typical disclaimer. I do work for the Air Force, but the views that I'm expressing today are those of my own, and so they don't reflect official policy or position of the Air Force, Department of Defense, or the government. Next slide. So just to give you a quick little snapshot of where all of our hospitals are located, we have 9 different hospitals that are Air Force hospitals. These here pictured are the ones that are in the United States. And so you can see we have hospitals located from California, Nevada, Alaska, from Mississippi, Florida, and Ohio. And the next slide will show those that are internationally. So we have a hospital in England and 2 in Japan. Our military hospitals typically care for our service members as well as their families. So even though we have locations around the world, typically our patient population is pretty stable and we treat the same type of individuals that are military members. Over, next slide. So how our journey started, in my role at the time, I was the perinatal nursing consultant for the Surgeon General. And so as an OB nurse, I recognized that we did have IBCLCs at all of our Air Force hospitals. However, there wasn't really an opportunity for them to network and to collaborate and look at the clinical care we were providing. So in December of 2020, we started a working group. And so my role in that was just to facilitate. I'm not an IBCLC, but I wanted to help advance lactation services. And so at that meeting, we developed a strategic plan, and our initial goal was to go ahead and implement the 10 steps during the calendar year 2021. And so in my role, I sent an email to all of the nursing leaders at all of those hospitals across the globe and notified them of our plan to implement this 10 steps and asked for their support to collaborate with the IBCLC at their hospital to make that happen. Our working group continued to meet each month, and our next step we took was to go ahead and develop a nutrition policy. Each of those hospitals did have their own nutrition policy, but they varied a little bit, and this is important because military nurses every 3 to 4 years, they move from hospital to hospital. And so every time they moved, they were having to learn new policy, new standards, depending on where they were located. So as a team, we came up with a standardized nutrition policy, and it was endorsed by the pediatric consultant for the Surgeon General as well to be used at all of our sites. So that was sent out right after we developed it in December, and we asked that everyone implement it by March of 2022, so not that long ago. The way forward with that is just continued implementation of our nutrition policy. We're going to work through each different challenges as they arise, and then continue working as a working group to advance lactation care across our military hospitals in the Air Force. Next slide. So just a quick recap of some of our successes and our challenges. Definitely one of the huge successes was the monthly crosstalk that we have every month, meeting with all the IBCLCs, giving them an opportunity to collaborate. Because before we were very siloed and working individually, and we weren't working together as a team to make stuff happen. The military structure itself has been very, very beneficial with rolling out things. Just sometimes bureaucracy can slow things down, but in this situation, just because of the structure, we were able to say this is what we're doing. And for the most part, people were on board and worked to implement the 10 steps. And then the collaborative efforts have been very important by involving our pediatric team, those clinicians, our IBCLCs, as well as our obstetric nursing team, and having everyone work together for the same goal in our strategic plan has been very helpful. As always, there's a few challenges. We did have some delays with the policy implementation just from some initial clinician concerns. And we don't really have a current means to require that everyone has implemented the policy, although they have. We didn't really have, a means to require that. So that was a potential challenge that we faced. So thank you for the opportunity to share. and I'll be excited to chat more at the end.
Thank you so much, Jeanette. I think that was really interesting, particularly as it's so recent, where you started your journey and the progress and successes so far, and particularly interesting to learn of the clinician concerns. I'm sure we look forward to hearing more about that later. Now, finally, we're going to Mexico, and we're going to hear from Dr. Colmenares. Dr. Colmenares, over to you.
Thank you very much. It is a pleasure to be here with you. And just as a breastfeeding collective, let us know that we cannot do these things alone. We have to be a collective all around the world to really commit with mothers. That's a final goal, to really help these mothers do what they want to do with their own possibilities and support. I would like to talk, next slide, please. I would like to talk about the association that we have in Mexico City. Well, in Mexico, it's Asociación de Consultores Certificados en Lactancia Materna. That means it's an association that congregates IBCLCs in Mexico, and not just in Mexico, but around the country. And we started around 2012 when the prevalences of breastfeeding in Mexico were going down, and we were amazed, like women need really support for that. So we identified each other around. We were just 21 IBCLCs in the countries, and then we share interests, and so we started to chat about the possibility to get together and do something. Next, please. So we started to make a community, and in this community, we empowered each other. And I think it's very interesting how this reflected the way we came together. And previously being 20 IBCLCs around the country, we started and recognized each other. And we knew that we needed an international recognition, and that's how ILCA recognizes our association as an international partner. So that's the way a CLAM started in Mexico, and this was in 2015. Next. And today we are 115 members. So we have been growing potentially very exponentially through the years. And being aware of the 10 steps, one of our main goals and our vision of this organization is to really support and encourage mothers through educations to healthcare professionals. And we know that IBCLCs are the recognized healthcare professionals around the world. And we have not just members in Mexico, but we also have members around in Texas, California, Toronto, and now that I am in the UK. Next. I am sure that all of our members have one position in training in their own places. So being around all the country makes the possibility to really expand the training and the high quality of training around. So this is one of the things we focused mainly in the organization and the conferences and in the universities in different parts of the country. And we really support, because we just know that's not knowing breastfeeding is great, but really helping healthcare professionals to be able to support the mothers in a practical way so that they can really do it as they wish. The next one. And we know that the world, the Breastfeeding Week, it's about educating. We had the opportunity to participate in the research of becoming breastfeeding friendly. And there we realized that education was we really need to educate our healthcare professionals. We do not have breastfeeding as an important topic around the university or pre-grade in medical doctors or nurses or in nutrition. So we knew that training is one of our main opportunities to really change the prevalence of breastfeeding in Mexico. Next one. So that's how it was born, the course in COVID. One of the good things that COVID would have left us was doing this online. We started doing on-site and it was just in Mexico City. But since COVID, we did this online, and it's a very interesting course because it's an hybrid course. We have it online in like Maine, and we have 6 different places around our country that have coordinators locally. And having these coordinators locally can give us much more way to get together with our students so they can work in the hospitals and access to the quality of training in the part of clinical with the patients directly. Now we are long-term providers of IBCLC, and we give CERPs to our students. So many of our students will become IBCLCs in the future, and we have a lot of healthcare, but all of them are healthcare professionals, and many of them are also doctors as students. So now we are 188 students that have at our course and around the country. Next one. And this gives us the opportunity to work together with them. So it's very interesting how being able to support and do clinical training on site with our students can give the opportunity for patients to really have a high standard quality of training of their own healthcare professionals. So here are some pictures about my students and our students around in different hospitals around the country and in milk banks and with the patients directly. Next one. And we have a liaison with some hospitals that already are accepting our students to be part of their own professionals. So it's amazing how they can have our students that would like to have the 1,000 hour of clinical practice that they need to become IBCLCs in the pathway 1, and they will have an excellent students that they have already all the clinical and all the theoretical support to continue doing their practice around the hospitals in the country, so that they can once become other healthcare professionals that support breastfeeding around. Next one, please. And I share with you the next February in Querétaro in Mexico, we have our annual conference. It's going to be the 7th annual conference of the association. So we really hope we can see you there. It's going to be in Mexico City. So thank you very much for the opportunity to talk about the training we have had in Mexico. Thank you.
Thank you so much, Dr. Colmenares. And I think, again, really fantastic examples of what initiated the work, which was the reducing breastfeeding rates in 2012, and how much progress you've made in the last 10 years. And again, really highlighting the importance of training and increasing access to skilled counselling for these mothers and the impact that that has. And thank you also for sharing the photos. I think it's always a nice reminder to really show us why this work is so important. So now you've heard some fantastic examples from across this region of the Americas. What we're going to do now is we're going to move into a 20-minute panel session. We're going to ask the panel some questions, and we hope that you can all learn from them sharing. They're going to hopefully tools and tips that we can adapt and apply to our local communities. And then we will follow up picking a couple of the questions that you're posting in your Q&A box. So again, a reminder, if you have questions for the individual panelists, you can also post them in the Q&A box. Or if you have general questions on breastfeeding as well, please feel free to do that. So I'd like if our 3 panelists can be available, I'll start with perhaps the first question. I think Dr. Colmenares already explained what the impetus was in Mexico for improving the 10 steps. But if I can go to you, Jeanette, why was this suddenly started and as recent as December 2020? What was the impetus to start investing in adopting 10 steps?
The main impetus was just allowing our IBCLC team to collaborate, because everyone was at their individual hospitals, and I think they were struggling a little bit with actually implementing all 10 of the steps. And so by working together as a team, and then with the support of the consultant role, they were able to then, press forward with it, because they had a little bit of top coverage to actually go forward and make folks do what they needed to be doing. Over.
Thank you so much. So again, advocacy from experts, really they're able to push this agenda and recognizing the extraordinary benefits and importance of focusing on the 10 steps. Dr. Lucas, perhaps you could explain to us what was that trigger that increased the investment in the 10 steps?
Yes. It's been very important, the technical assistance, the creation of teams to develop and implement the initiative. But the law has been a cornerstone, and its implementation to foster breastfeeding. The law says in its regulation the implementation of the 10 steps. So the public hospital must introduce and implement these steps. Of course, the Ministry of Health, with the support of UNICEF, PAHO, COTERMAC, which is the technical assistance for breastfeeding, develop every instrument, gave the technical assistance to define this implementation strategy of the initiative. So this has been extremely important, the law and its regulation, because before the law, the presence of companies at the hospitals and in activities done by the healthcare professionals was strong, and it was so difficult. It was to comply with many steps. Over.
Thank you so much, Dr. Lucas. And again, we can never underestimate and not emphasize the importance of putting in codes to protect against the aggressive marketing and promotion of breast milk substitutes. Dr. Colmenares, I'd like to come back to you. So 10 years, you've really been working on this, increasing the level of trained counselors, and by no means your numbers have really increased exponentially. And I appreciated your reference to having to pivot during COVID. Can you see how that has improved care in your community? Do you have any examples of that?
Improve you mean the education to the healthcare?
And improved breastfeeding practices in general.
Well, the COVID has affected, I think, around the world a lot to many hospitals. I think that many of the opportunities that hospitals had before, I think that breastfeeding indices were raising, and more people were really helping mothers, and many of our members really talked about the initiatives of skin to skin and practices that were really taking in the hospitals. And with COVID, I think that was like a very bad moment, because many of these things that have already been done had to go back again, and many hospitals in Mexico need to convert to be COVID, and many of the mothers started to be separated. So the fight that we have been doing all around to really assure other healthcare professionals that what we really support about skin to skin is it's science, and it has been very difficult to get there, and then suddenly they already they haven't changed that much, so they go back. So I think that we have to go a little bit back again and jump. I think that this is just a going down and then jump again, because we know that in the future, if we continue pressuring and really reassuring other healthcare professionals about the importance that these steps has for mothers, and that the support have for every mother and every baby and every family, it's so important that I think that we have to work again very, very hard together. And obviously, I think that the training to the staff in the hospitals is one of the most important things at all. I think that really supporting in the universities and in the hospital, it has the number one thing to be done.
Great. I think you're absolutely right. And I think, as you say, the one thing that COVID has shown is that it is possible to continue, but we need to do more. And there's babies being born every day. Our work will never stop, and we need to keep accelerating so that every baby, going back to Larry's presentation, the universality of the 10 steps, all babies have the right to access this. Jeanette, I'd like to come to you. One of the points that you mentioned related to challenges of clinicians. Could you elaborate on what you meant there?
Sure. When we sent the policy to all of our different hospitals for them to go ahead and sign and implement locally, we did have one facility that connected back with us, and they had some clinicians that had concerns with some of the language in the policy, just a difference of opinion on how the policy was written about risks of breast milk substitutes. And so just kind of working through that with them and the differences of opinion on the language and that type of thing was an initial challenge, but only one of the 9 facilities had that. So thankfully that wasn't a huge thing across all our sites.
And how did you overcome that? And how do you kind of, for future challenges, given that you're quite early in this journey, and based on maybe perhaps what you've learned from the other panelists, what can you take away that you would apply in your work going forward?
So with that one, it was just a collaborative discussion where at that facility, the IBCLC, the pediatric team, and the obstetric nursing team sat down together to look at the language and look at that, the latest evidence that's out there and kind of come to a consensus on that. But again, the policy is standardized across the military. So there really wasn't an opportunity for them to change language. They just needed to talk about how they were going to implement locally.
Great, thank you so much, Jeanette. And again, it's the importance of bringing together people who know what they're talking about and making sure they have a voice on the table and the opportunity to review standards and align to the best practice and global evidence that we have referred to on several occasions throughout this webinar so far. Dr. Lucas, can I come back to you? You mentioned earlier about some of the challenges of the violations of the code. Were there any other challenges that you faced in Bolivia? And if there were, how did you overcome them?
Es un desafío para nosotros expandir.
A grand challenge for us to expand the initiative. Currently, we have only established about 18 or 19% according to what hospital initiatives should implement. So the need to expand is definitely a grand challenge, but accreditation as well. It does require important follow-up, a follow-up to the 10 steps implementation. So we have a grand challenge before us. How can we work with hospitals once they're accredited? How can we make sure that they actually continue with the 10 steps? And for this reason, Bolivia is thinking about developing tools for self-assessment, just as the continuous improvement cycles in such a way that the team reviews and evaluates or assesses the implementation of all 10 steps. We believe it's a grand challenge, and hopefully by next year, we shall be able to consider and reassess actions to implement and provide continuance to the hospital's accreditations, and at the same time assess the other strategies related to expanding or extending the initiative's scope. Just as Mariana stated, technical assistance and human resources and resources in general are essential, and also the breastfeeding committees. In Bolivia, about 90% of the facilities are first level facilities, out of which 70% are auxiliary centers with auxiliary nurses only. In Bolivia, it's a grand challenge. How can we include compliance on certain items included in the initiative at set sites in such a way that we all align to the first, second, and third level of attention, since they all attend to pregnant women, and how important it is for them to deliver the correct information to the pregnant mothers and to their families for them to understand the importance of breastfeeding. I believe there are grand challenges. However, there are some key elements we must address according to what the country requires: technical assistance, the resources, because definitely human resources and training requires this support. Since when we work with training hours, they're not short hours of training, and they evidently require an entire strategy. Over.
Thank you so much, Dr. Lucas. I think you brought up some very pertinent points there. And the issue again of sustainability. Earlier we mentioned universality, and now again the second objective when the guidance were updated was the issue of sustainability. Once facilities and hospitals have reached the level they need to be, how do we sustain that level of excellence so that those future moms and future babies can continue to get access to that care? And how do we make sure that these steps are integrated across all parts of the health system and not just with with the experts who know what to focus on, but that everybody involved in delivering that service is well aware and fully implementing the standards of care as needed. Perhaps, Dr. Colmenares, could you talk a little bit about how, when you identify sort of best practice or advocates that you feel are pushing the agenda forward in Mexico, have you identified some of those sort of catalytic individuals or actions that really help in driving this agenda forward? If you've got any examples of best practice that other countries can learn from.
Well, yes, I think that since 2012, after that health survey that was really impacting for everyone about the 7% of breastfeeding in Mexico. Before it was much better, so that made everybody really start to question what has been done, because in 1991 the UNICEF started in Mexico with the first hospital, the baby-friendly hospital. So what was happening around? No, so it's very evident that in countries as Mexico, they do not respect the code, no, and we have the formula companies really into the medical schools and into the pediatric associations all around. And that is one of the main things that we have been fighting through all these years. And I really think that there are many advocates around. We have been collaborating. Well, the Born of a Clam as an organization that was recognized throughout since the beginning was a very important catalyst, for other organizations and other people to become part of this. And even though we are just IBCLC, and we decided like that because we didn't want to start from zero. We really wanted to push the IBCLC's formation in Mexico. That was one of the things that we really liked, to do the training, and the training as a gold standard. No, it doesn't mean that other people don't know about breastfeeding. It means that the gold standard is an IBCLC. But we have collaborated with the National Health Institute. We have collaborated in many research projects, and as we have many people from around the country, everyone in their own places really work with their own agenda locally. So that's what I think is one of the most important things. And about the course that we offer in ACLAM is that we have the main thing, the theoretical part, but we have people that represent their own places. And I think that that's very interesting about this, because we can do liaisons locally with the hospitals, with the organizations, with the collectives that locally work with the mothers, but because finally I think that the standard of care is the final point is really helping mothers and babies, and they really need people to be aware and really be good in competencies in breastfeeding support. So we do have a lot of people that is working very hard around the country, I think. And in 2018, we got the new survey, and from 14-something% of breastfeeding, we went to 28%. So I think that it has been going up. I think that COVID will really impact, and we have very nice research about the impact of COVID around in the hospitals, and the formula enterprises are really pushing, and the earthquake in 2017. So there are many things that it's like we really need to break hard things. No, we really need to work hard and continue doing the work around them. I think there are many advocates are really working.
Thanks so much. That's really inspiring and great to hear of the progress you've made. And I think that's what it comes down to. This is translating into more babies being exclusively breastfed and continue to breastfeed. And ultimately, this will have only positive outcomes on their future health and survival, and of course also for the mother. So this is not about something nice to do. This is about the right thing to do, and the fact that all mothers and babies have to access this important support. I also liked how you recognize that this is a whole of society function. Frankly, it's not just with the skilled counselors, it's not just with the experts in hospitals, but we have to engage local communities. We have to make sure that mothers at every level of our community have access to those right services. Maybe Jeanette, you can speak to us a bit about the moms that you're supporting and how are they responding to this initiative. And again, as this is something relatively new, I think we're all really excited to hear from you. What lessons and advice would you have from what you've learned so far to others who may be doing something similar? Thank you.
I think the moms and families are very pleased with, the move that we've made for this. I think each hospital was doing parts of it in some respect before, but now that it's standardized, that has helped a lot, because when, families come to our facilities, they expect that we're doing evidence-based care and that we're providing, appropriate lactation services for them. So that has been well received. And I guess the biggest takeaway I would say for this, and the other panelists have made mention of it, you can't do it alone. You have to get other people on your team and other disciplines. So like the pediatric community, the obstetric nursing community, the IBCLC community, everybody has to come together toward like a strategic goal, and kind of having that goal and then coming up with an actual plan or steps to get there, little stepping stones to just be, to get to your end goal, and not just a vision, but you have to figure out how you're going to do it together.
Fantastic. I really appreciate that. And of course, we all look forward to hearing more as your program evolves and hearing the great results. Dr. Lucas, if I could come back to you. If you were to give one major obstacle that you have faced, clearly you've been working in this area for 30 years. You have worked with Indigenous women's groups, particularly for these more marginalized populations. What are some of the challenges that you faced with implementing the 10 steps for these communities, and what advice or what actions did you take to try to overcome them?
Bueno, en las comunidades indígenas y en familias indígenas.
In indigenous communities and in indigenous families, how important it is for us to reinforce maternal breastfeeding. In indigenous communities, and several that we have in Bolivia, breastfeeding is a practice that has always been conducted. And they promoted milk substitutes. And this has caused mothers to include breastfeeding and substitutes in their daily nutrition. It's fundamental for us to reinforce these practices, because communities do have what we are trying to emphasize. And when we speak about exclusive breastfeeding, they would before give them mate, waters, broths for children below 6, with less than 6 months of age. So what we're trying to mostly highlight is the exclusive breastfeeding. It will continue being a challenge, and a challenge is to continue implementing the law in such a way that all health establishments comply with it, either in indigenous communities as well as in non-indigenous communities, always considering the practices and promoting maternal breastfeeding. It's fundamental for us to promote maternal breastfeeding, and obviously the Ministry of Health is within the policy, since they are included in the Ministries of Health policy. It is part of the Ministries of Health policy to promote maternal breastfeeding, exclusive breastfeeding. We are not just working from health establishments, we're also working with other instances such as maternal. We're trying to work with different facilities, trying to facilitate breastfeeding, and we are coming up with future actions that in one way or another are definitely helping and support the implementation. Of course, led by the Ministry of Health and entirely by the Nutrition and Feeding Program. Over. Thank you.
Thank you so much, Dr. Lucas. And I think it's so important to recognize that we have heterogeneous populations, they have different needs. And when we are designing our programs, as you've just described here, we need to take into account the specific needs of those populations and adapt our programs accordingly. So now, for the next 10 minutes, I'm going to pick some of the questions that you have been posting. I know that many of our colleagues online, our esteemed panel of experts who are quickly answering a lot of questions, have been answering, but I would still like to pose some of them to our panel here so that we all may hear from you. One very good question, and I'll put this out to all of you. Are we targeting all hospitals? what about the private hospitals, and how do these programs, particularly in Bolivia and Mexico, how are we addressing the private sector? So I don't know who'd like to speak first. Perhaps Dr. Colmenares and then Dr. Lucas.
Well, yes, it's a very interesting thing because in Mexico, the programs are implemented in public hospitals mainly, the governmental programs. But there has been a lot of initiatives in the private hospital sometimes, and many of them has been started because of the interest of the mothers, that really look for a hospital that can support their journey, in breastfeeding practices or in correct birthing practices. So I think that one of the good things is the advocacy the mothers do, the support groups do, different groups around the country that really push to private hospitals. So in certain way, there has been a change. Maybe for the hospital, it isn't the change because they're really committed with breastfeeding, but with mothers and money, and for them going with them. Maybe that's the main mobile or the first mobile, but I think that's a very important way to start doing things, So what we do, because many of us also did work in private hospitals, is that trying to advocate with mothers directly. Like we have different ways we can access for the mothers, the health training professionals, but also them really asking for the support for skin to skin, for example, and really look for those kind of practices. So I think it's moving on also. I think it's something that's happening all around, and it's because that's much more knowledge in women and in families about the importance of breastfeeding. So the thing is, now they really go through that, but they really get with all this in front of many bad practices they have to encounter. So now we have to change those kind of steps so they can run smoothly through their passage.
Thank you so much. Great points. And again, we need our mothers to demand the service. They have a right to it, and they need to insist that they get it, and make sure that wherever they are going to deliver their baby, that they have access to these 10 steps. Dr. Lucas, what happens in the private sector in Bolivia?
Sí. Bueno, el sector privado en Bolivia, en realidad...
The private sector in Bolivia truly presents... In order for us to continue with the initiative, it is required for a team to exist in these hospitals in a permanent form. In Bolivia, we have hospitals with staff that is in high rotation. However, we've had requests in order for us to implement the initiative. However, if public hospitals, we've had tremendous spaces, but at the same time, we have a different group of health establishments or facilities that correspond to private entities, to the National Health Service. These are all short-term actions within Bolivia. We have requested, and the hospitals have requested to the Ministry of Health, specifically to the nutrition program, they have requested actions to implement the initiative, to start with its implementation. That's crucial. And once again, I want to highlight that the law establishes that private institutions need to apply everything related to maternal breastfeeding promotion or exclusive breastfeeding. However, we have included this in Bolivia in one way or another, and we now have more requests to advance. However, and just as we have seen in Social Security, and since they participate in the activities related to the Ministry of Health and the public part, they have emphasized that within maternal control, we have information on breastfeeding and the regulations established in the law. Over. Thank you.
Thank you so much. And again, important that the law applies to everybody, not just public sector. Jeanette, one of the questions was, how do you reduce the use of pacifiers for newborns? Do you have any tips that you'd like to share?
prenatal education, I think, is important. Again, I'm not an IBCLC, so I'll refer to the colleagues on the line, but yeah, prenatally and just having a collaborative discussion with the families of the risks and benefits of not using them.
Thanks so much, Jeanette. Okay, moving back to you, Dr. Colmenares, there's a question on breastfeeding multiple infants. I myself am a twin. Can you share your experiences about some of the challenges and how you overcome to help the implementation of the 10 steps, but taking in mind multiple?
Yes, well, whatever is not normal, no, like or common, sometimes it's much more challenging, no. And we have in Mexico one of the countries with highest C-section at all. Like we have around 75% of C-section, and that's one of the things that have to change. And if there's a lot of C-sections in babies that are just one with twins, like almost always they have a C-section, even if it's not needed. No, so first of all, the changing in the birthing practices is one of the main targets of that. I think that things have to change from the beginning, because if we really want to change things, we have to change, as Janet said, from prenatal. We have to work with mothers prenatally. And having a twin, no, we know the ones we are mothers, that having one baby is also difficult. Having two babies is the double. and breastfeeding one baby is difficult. Breastfeeding two babies is much more difficult. So the support they need it prenatally. They need good support in birthing. They need skin-to-skin contact. They need rooming. So all the 10 steps have to be done as usual in these babies that are born multiple. No, so if we, that's what I really talk to mothers. No, if we have things that might be difficulties during breastfeeding, we have to do all the rest of the things that can encourage a better breastfeeding or a successful breastfeeding, you know. So the 10 steps are applicable to everybody. So being more and these families to know what they need to ask for and really commit with that at the hospital, I think is one of the first things, the important things to do. And then obviously the support they receive from a breastfeeding expert in the moment the babies are born. Not just twins, but maybe other multiple. So we have to be there. And we know that now with all the reproduction assist things, we have a lot of multiples also. So we have to support the mother. We have to support the attachment. We have to support latch. We have to support breastfeeding, the amount of breastfeeding, breast milk production. So there are other things that we have to be really supportive. So I think that the IBCLCs there are really an important part of the healthcare professionals that support these families. What we are really looking forward is that in Mexico, the hospitals have breastfeeding groups and breastfeeding policies that are really strong, so that they can support these mothers just as they support everyone. You know? So being part of the support.
Great, thank you so much for highlighting all of those points very eloquently. And of course, as you say, the numbers of multiple births will only increase, so we have to place more attention on how we support these mums much earlier in the prenatal period. Dr. Lucas, could you share any experiences you have you faced challenges with the external monitoring of the Baby Friendly? Do you have any recommendations to share if you have faced challenges for our listeners?
En relación al apoyo a la lactancia materna fuera de los establecimientos.
In reference to health facilities, it's necessary for us to establish support groups in the communities, even though it's not an easy task. It's a very important, it's very difficult, especially in rural locations. Important for us to support from the communities, and in some occasions it's only one person working at the health facility, and I feel that the community support is crucial. It's a little bit more complex within the city. And we have to consider how we may reinforce groups through our health staff. And since with technology, we have learned through COVID how important it is to use WhatsApp. WhatsApp facilitates our communication, and we need to assess this type of strategies specifically in urban areas. I believe we can work on these matters. It requires greater efforts. However, it is important in order for us to support others, and we have seen this with the emergency. Over.
Thank you so much. And really, what a fantastic panel. Thank you so much for sharing your insights, your experience, and for coming on with a large group of people. We had close to 400 people online. So I would really like to thank all our panelists for their fantastic words and for sharing their personal experiences. And also I'd like to draw everyone's attention. We've got a couple of minutes left. Please look at the chat. It's exploding with fantastic tips and information and sharing contacts. I think we have such a passionate group of breastfeeding experts and professionals and committed people online. And I mean, I look forward to trying to have a read of all of them later. So now we are going to wrap up, and coming to the end of this session, it's important to see how can we all add our voice to this particular subject. You may remember earlier in the year that WHO and UNICEF released a very important report, a multi-country study on exploitative marketing by the formula industry and how that does affect women's choices to breastfeed. And as a result of that, we did create a call to action, and there's an open letter. So if you click on the QR code here, you'll be able to access the link to the WHO website, and you can sign up to that. And make sure that you share it amongst your community too. You can also share on your social media platforms the hashtag End Exploitative Marketing as well. In addition to the call to action and the open letter, we also encourage you to, if you are part of an organization that advocates for breastfeeding in your country or region, consider to become an associate of the Global Breastfeeding Collective. The link is on the screen. You can click there and you'll get information about how you can join. So now my closing slide, I would like to thank all our speakers, all our organizers. As you can imagine, there have been weeks and months of work behind this fantastic webinar, and including the earlier webinar that we had for the Africa, Asia and European region. There were a whole load of members there online, and of course there's all our speakers as well and many other people behind the scenes. We have an amazing ICT team who have been getting up at 2 a.m. and 1 a.m. in the morning. So thanks to all of you for all your fantastic contributions, and also to the mothers who created that beautiful video that inspires all and reminds us all of why we need to do the work that we do. So as we close the first part of this World Breastfeeding webinar, I'm delighted now, and please ask you all to stay online. We're going to hand over to the next session, which is a 30-minute session, and it will focus on 2 key ways that you can step up to save lives. I'm delighted to hand over first to, well, Jodine will start, but I'm going to introduce our speakers on that session. So we have Nikki Connell from the Emergency Nutrition Network, who's representing the Mammy Global Network on enhanced lactation support for small and nutritionally at-risk infants under 6 months. And then she'll be followed by Jodine Chase from the Infant Feeding and Emergencies Core Group, who will talk about what's next for infant and young child feeding in emergencies. So I'm going to hand over to you, Jodine, and I look forward to hearing this session. Thank you and goodbye.
Thank you so much, Grania. Thank you very much for what a wonderful presentation that we've just seen. And thank you to the Global Breastfeeding Collective for hosting us. Welcome to 2 more reasons to step up. I'm Jodine Chase, the Infant Feeding and Emergencies Core Group Facilitator. And first, as you've heard, we have a presentation from the Mammy Global Network, represented by Emergency Nutrition's Nikki Connell. And then afterwards, I'll be coming back to present a new report that's being launched today. Please do post your questions in the Q&A as you think of them. Our team of volunteers will answer some questions directly, and some will be answered by me and by Nikki during a short Q&A at the end of our presentations. Over to you, Nikki.
Thanks, Jodine.
Hello everyone, as Jodie mentioned, my name is Nikki Connell and I'm a Senior Technical Associate with the Emergency Nutrition Network. We're delighted to join your webinar today and see how we can join forces to enhance breastfeeding support and continuity of care for small and nutritionally at-risk infants under 6 months of age and their mothers, what we refer to as Mammy. We will introduce the Mammy Care Pathway Package and how it can help put step 10 of the 10 steps to successful breastfeeding into practice. As a reminder, step 10 is to coordinate discharge so that parents and their infants have timely access to ongoing support and care. So what is the problem we are facing? Mammy refers to the management of small and nutritionally at-risk infants under 6 months and their mothers. Small and nutritionally at risk includes infants that are born too early or too small, babies that may be born wasted, underweight or stunted, and those that become malnourished or falter in growth after birth. Millions of infants are affected in the world, as shown by the figures on the slide, and this is a problem across both humanitarian and development settings. Overall, globally, 1 in 5 infants under 6 months is small or nutritionally at risk. These infants are at higher risk of illness, death, poor development, and long-term ill health than their healthy counterparts. For example, an infant with severe underweight in the first 6 months of life is nearly 5 times more likely to die than a healthy infant. Nutrition for Growth commitments, which outline country commitments to tackling malnutrition in all its forms, have recognised the need to target services to small and nutritionally at-risk infants and their mothers if the required progress is to be made. For example, Ireland has committed to take a leadership role on the issue of wasting globally, and in particular, programming targeted at small and nutritionally at-risk infants. So the political leadership is there to address this issue, but we all need to support progress in practice. Step 10 of the 10 steps to successful breastfeeding translates to coordinating discharge so that parents and their infants have timely access to ongoing support and care. At present, we see a gap in practice for vulnerable infants and mothers, particularly from when an infant is aged 6 weeks to 6 months. We see poor continuity of care for at-risk infants beyond the immediate postnatal period. Proactive screening for problems is not common. For mothers and infants that do present to health services with clinical or feeding problems, specialised support for breastfeeding up to 6 months of age is often lacking. And we have an over-reliance on inpatient care, with community-based outpatient services rarely available. Breastfeeding is critical to the survival, growth and development of children worldwide, and it's especially so for these young infants who are the furthest left behind. We are here today to see how we can work together to close the care gap and improve access to breastfeeding support for these infants using the Mammy Care Pathway Package. The Mammy Care Pathway Package is a piece of implementation guidance that comprises a care pathway framework, user guides, and health worker support materials, including forms, counselling cards, and a support actions booklet to assist practitioners to identify, assess, and manage small and nutritionally at-risk infants under 6 months of age. Yes. The Mammy Care Pathway Package applies an integrated care pathway approach with a view to achieve continuity of respectful quality care for infants and their mothers across health and nutrition services. It was developed by the Mammy Global Network, led by the Emergency Nutrition Network and the London School of Hygiene and Tropical Medicine, to help put World Health Organization recommendations for community-based care into practice. Skilled breastfeeding support is central to the Mammy Care Pathway as part of a broader package of clinical care and social support. Mammy covers both maternal and infant health and nutrition, as well as referring pairs on to relevant social and child development services available. Mammy links prevention and treatment. But how does Mammy fit in with the breastfeeding services you are already providing through IYCF programming? Mammy dovetails with IYCF interventions that operate more at the primary prevention level. Mammy focuses on secondary prevention, the early detection of problems with timely intervention to prevent further deterioration, and also tertiary prevention, which is urgent action to prevent serious consequences of problems should primary and secondary prevention fail. IYCF and Mammy are both essential and complementary initiatives for infants and their mothers. This is a busy slide, so don't worry about reading every detail. What you are looking at on this slide, on the y-axis, is the level of healthcare, so community level, secondary and tertiary health facilities. And on the x-axis is the stage of care. And what we're focused on is the early postnatal period and the period 6 weeks to 6 months. The Mammy Care pathway applies, builds on and connects existing nutrition and health services across primary, secondary and tertiary care. Care is focused at the community level where there is the greatest gap. Screening can happen from pregnancy right through to when the infant is 6 months of age at a range of health contact points. For example, the infant's first vaccination at 6 weeks. Moderate risk infants and their mothers who are identified and enrolled in community-based care receive individualised support and counselling for specific feeding and clinical problems. Those that are at high risk are referred to inpatient care until they are considered moderate and can be referred into outpatient care. And all infants are enrolled for support to 6 months of age. So how is the breastfeeding support provided to these infant mother pairs different and complementary to what might be provided in community breastfeeding support programme? First, this is a package of care that targets skilled breastfeeding support to at-risk infants under 6 months and their mothers, rather than to the general population of infants. The needs of these infants may be more complex and the implications of not getting it right even greater. Secondly, skilled breastfeeding counselling is embedded in a larger package of clinical and social care. This may involve referrals to clinical services, maternal mental health services, and other context-specific support that the pair may benefit from. Thirdly, infants and mothers receive regular and continuous support up to 6 months of age and are not discharged from services until that age is reached. And lastly, as the mother-infant pair are being seen regularly, at-risk infants and mothers remain on the radar of the health service, so they are primed for early intervention and referral for specialist care if required. Here is an example of how step 10 might look in practice. This example is from a humanitarian context. In 2021, Save the Children were providing services to Venezuelans arriving in Colombia. An assessment found that the rate of exclusive breastfeeding was decreasing with age, from 91% in the first month, reducing to 26% at 5 months of age. A Sexual Health and Reproductive Unit, or SHRU, was set up to provide checkups of prenatal care, family planning services, psychosocial support, and newborn medical attention for infants up to 2 months of age. IYCF services were also provided to promote, protect, and support breastfeeding. However, small and nutritionally at-risk infants and their mothers were not getting the support they needed from the SHRU, as services were only available for infants up to 2 months of age, and IYCF services could not follow up the individual mother-infant pairs to provide continued care. So a Mammy programme was initiated in the SHRU. Vulnerable mothers and infants were referred to the Mammy programme, creating continuity of care and providing targeted feeding support alongside existing clinical, mental health and food security services to provide a complete package of care. The Mammy services were linked with existing community, inpatient and postnatal services for screening and referral as required. To find out more, please see a link in the chat to a video showcasing interviews of mothers enrolled in this programme that should be available shortly. So we now know that putting step 10 into practice is critical to realising continuity of care between health and nutrition services for at-risk infants under 6 months and their mothers. Early identification of at-risk infants under 6 months is an essential action to prevent further decline in the nutrition status of an infant, and the Mammy Care pathway can support this. It's also clear that skilled breastfeeding counselling is a core component of care for small and nutritionally at-risk infants, a service that needs strengthening in community-based outpatient care. We have a common goal to achieve coordinated discharge so that at-risk infants under 6 months and their mothers have timely access to ongoing support and care. We call on you to join the Mammy Global Network's efforts to work together to reach the most vulnerable and at-risk infants and their mothers. Thank you for listening.
Thank you, Nikki. Hello again. I'm Jodine Chase, the IFE Core Group Facilitator. We've been called to step up for breastfeeding in this webinar, and we have already learned so much. This last section is about how we are called to step up during emergencies. So we all know these numbers. Almost 90 million people forcibly displaced by the end of 2021, and the rate of displacement due to climate change is twice the rate due to conflict. Children are 30% of the world's population, but they make up 41% of those displaced. Suboptimal breastfeeding leads to over 820,000 deaths per year, while exclusive and continued breastfeeding alongside complementary feeding is the single most effective intervention to prevent deaths in children under the age of 5. When protective actions like the 10 steps to successful breastfeeding are in place, when Mammy Care is available to support the most vulnerable infants, communities are more likely to be breastfeeding communities, and these are better prepared for emergencies. Disasters and humanitarian emergencies disrupt breastfeeding, and additional support is needed, both to preserve breastfeeding and also for the food insecure, including those partially or fully dependent on infant formula. We heard earlier this year from WHO how the pervasive, misleading, and aggressive marketing from the $55 billion formula milk industry causes harm. This is especially true during emergencies, which are often exploited through floods of donations and uncontrolled distribution of breast milk substitutes and infant foods. This undermines appropriate infant and young child feeding practices, both during the emergency and beyond. About 20 years ago, the IFE Core Group was born. It's a global collaboration of agencies and individuals, and we developed operational guidance with evidence-based actions to safeguard life-saving infant and young child feeding in emergencies. In 2010, the World Health Assembly urged member states to adopt the guidance into their own preparedness plans and emergency response. So now, 10 years since this call to countries for action, we are releasing the first ever report to examine the progress of member states in fulfilling this commitment. The report has found that progress is being made at the policy level. At the same time, coordination, capacity, and clear systems for tracking progress are lagging. There are gaps in functional multisectoral systems to support recommended infant and young child feeding practices in emergencies. This report aims to galvanize member states and the humanitarian and development community to deliver on their global IYCFE commitment. Countries are taking measures. An increased proportion of countries report in NutriDash that they're working on programs to support appropriate IYCFE, from 62% in 2016 to 78% in 2020. Kuwait and Lebanon implemented all elements in 2016. Nigeria developed a plan in 2018 that links emergency activities to existing policy and nutrition plans. The global trend in government funding beyond staff salaries has increased over time, but it remains well below the number of countries that report work or the presence of policies, strategies, or action plans. Until 2019, no region had more than 40% of its countries reporting funding beyond staff salaries. Available data suggests significant gaps in the availability of activities that support caregivers in nourishing their infants and young children in emergencies. These gaps exist despite the evidence that these behaviors and the services supporting them are life-saving. Current global data is inadequate to assess the numbers of people that need action, to track unmet needs, and to assess the impact of the emergency and beyond. There are no formal mechanisms for member states to measure their progress, and there's no requirement for them to do so. There's no consensus around methodologies for analyzing data in global databases to distinguish between emergency and non-emergency contexts. Member states have the primary responsibility to provide leadership, policy, funding, monitoring, and coordination for preparedness and response to emergencies. While progress has been made, we can see there are many gaps. Governments must take the lead, and this report offers 6 recommendations for member states. A systems approach is needed, and 6 recommendations are also offered for humanitarian and development communities, recognizing the important and synergistic contributions they make towards creating environments where caregivers can consistently nourish their infants and young children. The first recommendation for governments is to step up and ensure that national and international preparedness plans and emergency responses include adequately funded actions as outlined in the operational guidance. And the humanitarian and development community is also being asked to step up, deliver, develop policy advocacy agendas to promote uptake of actions as outlined in the operational guidance. In the words of Victor Guello, Director, Nutrition and Child Development, UNICEF, who we heard from earlier, and Francesco Branca, Director of the Department of Nutrition for Health and Development, World Health Organization, Geneva, the COVID-19 pandemic has made it clear that all countries are at risk of an emergency. Now is the time to consolidate gains from the global emergencies of the past decade and to channel these gains into our routine systems and into our preparedness and response capacities. How can you step up? Please start by downloading the report, which will be shared widely in the coming days. You can use it as a tool to start a conversation in your country and to hold those responsible to account. Thank you. And we will now have some time for questions and answers. I want you to note, please, that they will be shared in a document on our website in the coming days after the webinar. So even if the questions aren't being answered right now, you'll be able to look it up and find answers later. So Nikki, here's a question that applies to both of us. And I want to reference too that quite a few of the resources that you may have questions about are going to be shared or have been shared in the chat already. So Nikki, this applies to both of us. Can these resources or guidance be used in any country or any setting, or are they specific to developing countries or emergency settings? And I'll answer for IYCFE. The answer is yes. A good example is how Ireland will use the operational guidance to develop their own plan in a non-development setting within Ireland. Thinking about the operations guidance more broadly, it's been used in a lot of countries, including in my own country of Canada, and it's certainly relevant to strengthen support for optimal infant feeding. I look forward to following what Ireland is working on in the next few weeks and months. What about for Mammy, Nikki?
Yes, thanks, Jodine. And it's the same answer for Mammy, actually, that the Mammy care pathway can be used in any setting where there are vulnerable infants, which includes both development and emergency settings. We know that support for skilled breastfeeding falls way short in Ireland and the UK, for example, including in health facilities. And the reasons why infants may be at risk in these settings could include premature infants or infants with a disability. And of course, you find those infants all over the world. So like anywhere, the materials are designed for adaptation and contextualization, depending on the situation that you find yourself in.
Right, and we've had another question about how training on lactation management and support can be found. And I know we certainly have resources available on the IFE Core Group's website. And I know that the Emergency Nutrition Network website has a lot of resources to support that. Here's another question for you, Nikki. The person asks, if I want to get involved in Mammy and support vulnerable infants and mothers in my context, what would be the first thing I need to do?
Another good question. And I would say, first off, download the Mammy Care Pathway package from the ENN website, the Emergency Nutrition Network website. We host the Mammy Global Network webpage, so that's a good place to start. And the link has been shared in the chat already. And Aisling, I can see, has just shared it again now. It's important to have that document, but then, of course, review and see how it can be adapted and applied to your context, and then gather relevant stakeholders across both the health and nutrition sectors to discuss what the needs are in your context, what the current service situation is, and where the gaps are, and how the Mammy Care Pathway could be applied in your context. It may not be possible, of course, to provide or access all the services that are outlined in the Mammy Care Pathway immediately, but that's okay. Don't let that stop you getting started. You can start off with what is available and then build up the services as you go. And plus as well, it would be useful, I think, to join the Mammy Global Network. Anyone can join, feel free to sign up. And that will enable you to connect with other service providers in other contexts, so you can learn from each other and you can share questions and brainstorm answers together. And details on how to join can also be found on the Emergency Nutrition Network website on the Mammy Global Network page. And I believe that's also just been shared in the chat too.
Yes, perfect. We have another question about the evidence base. What is the evidence base to show that the Mammy Care Pathway works?
Well, of course, it's been developed based on as much evidence as we have. There's been a lot of evidence generated and also being generated currently, which has been drawn on. So the core contents of the Mammy Care Pathway package are based on and are intended to help operationalise the WHO guidelines for the management of infants under 6 months with severe acute malnutrition that were published in 2013. The WHO guidelines are currently under extensive revision and are specifically looking at prevention and treatment of growth faltering in infants under 6 months. And these recommendations are due out end of this year or early next, hopefully. So the package builds on a broad range and a variety of accumulated evidence and experience, and applies well-evidenced interventions like the Integrated Management of Childhood Illnesses, IMCI, and breastfeeding counselling to the context of the most at-risk infants and their mothers. So significant research is underway or planned to build a direct evidence base, including a randomised controlled trial in Ethiopia, state-level research in India, and also an intervention trial in South Sudan. And there's been previous research and evidence generated in Bangladesh, Ethiopia again, and other contexts. Rwanda is another example as well. And suggested interventions that are included in the Mammy Care Pathway package are fundamentally behavioural and in nature, and also low risk. But of course, they have a high potential for benefits to these most vulnerable infants.
I'm seeing a couple of questions over the last while related to multiples, and we have one specifically about support for multiples for us as well. And I know that many of our breastfeeding counselors and skilled lactation supporters work with families, especially in referrals around multiples. So can you answer, maybe perhaps in more general terms, can IYCF counselors deliver any aspect of Mammy services?
Yes, indeed. You know, I'm sure many on the call will have had an experience of trying to support a more vulnerable infant, and we know that they have sometimes more specific needs, depending on the context, depending on the situation. And I think what makes the Mammy Care Pathway so important is that it takes existing skilled counsellors who are available, who are well trained in lactation support, but gives a platform to provide closer follow-up and ongoing follow-up for those more vulnerable infants, as well as access to other services to provide a more complete holistic package of care. So any lactation counsellor can pick up the care pathway package and see how it can be adapted to their context. And that's really the beauty of it, not a prescribed guideline, that where you have to have certain building blocks in place. It really is designed as an approach that can be integrated into existing services that are already there. So it really can be picked up by anyone and applied to their context.
That sounds terrific. Thank you very much, Nikki. This has been really important, I think, for our audience to learn more about the Mammy Care Pathway. And also, we were so excited to be able to launch our report today. So just a reminder that on our website, we've shared some links. You will be able to access some more of the answers to some of the questions that have been asked, and the Q&A that we've talked about here that we've verbalized will be repeated. I'd like now to thank our longstanding donors and partners who support the Mammy Global Network and the IFE Core Group, and who funded the development of the report that we discussed today: the USAID Bureau for Humanitarian Assistance, Irish Aid, and the Eleanor Crook Foundation. Resources and references are at the link that has been shared in the chat. There are some orientation videos available for Mammy. There is also information you can see Mammy in action. Save the Children and Goals Mammy experiences are available in Bangladesh and in Ethiopia. And also, just if you're interested, please get involved. Join the Mammy Global Network, and also visit the IFE Core Group website if you would like more information about support for infants and young child feeding in emergencies. And that wraps up our presentation. And there are some references for the materials that we presented. And I thank you all for staying on and listening to us talk about 2 more reasons to step up.